All right, hello everyone. Welcome back to this class on anesthesia part 2 revision. Are you guys able to see me and hear me well? Is the streaming fine? Are you guys able to see me and hear me well? Okay. So let's begin with the part 2 of this revision. Just hold on one second. Okay, so we did all the different types of LMAs, laryngoscopes, tubes, oxygen delivery devices, airways in part 1, different kinds of positions in anesthesia, all that machine of anesthesia, circuits, everything was done in part 1. So anyone who has missed it in part 1, please go and watch that later. Now part 2, we will mainly be doing the drugs, the pre-operative instructions, what are the airway tests that are important, and also we will be doing about regional anesthesia a little bit. Okay, so let's begin with our class for today. The Plus subscription on Unacademy will help you get access to both live and recorded classes. You can learn from India's top educators, and you can access our question bank with 25,000 plus questions. The iconic subscription is a partnership between Unacademy and PrepLadder, which will help you get the best of both worlds. You can get the video lectures, live lectures of Unacademy and the video lectures of PrepLadder. We have a few grand tests going on right now which are free. Then we have all these features in our special classes. You can raise a hand, you can ask questions, you can get the lecture notes PDF at the end of the class. This is our question bank. These are our NEET PG toppers, and these are a few of the plus courses that are going on right now. The clinical case and discussion batch, the target next integrated batch 2023, and NEET PG 2022 batch. And this is my code Dr.Jhanvi Life. If you guys would like to buy the plus subscription of Unacademy, you can use my code and you'll get 10% off on your subscription. Now, one very important announcement that I have for you guys, as you know already, the Focus FMGE batch is going on. Okay, so in this batch, they are going to take all the subjects a little bit more in detail for the FMGE exam. And in this batch, I'm going to be teaching anesthesia next month, that is in November. Okay, so all of you who want to join the Focus FMGE batch, again, you can buy the plus subscription at least for a month. You can use my code Dr. Jhanvi Life for the same. All right, so let's begin with our next part of anesthesia revision. So can anyone tell me what all do you see on this slide? What all are you able to see on this slide? Yes, very good, Ashutosh. What are all these equipments that you see? Different types of needles. What are they used for? What is the type of anesthesia that we give with it? Okay. So what is 1, what is 2, what is 3, and what is 4? Okay. So let's have a look at number 1. Number 1 is nothing but a spinal needle. Okay. Now, can anyone tell me what is the main 2 uses of spinal needle? First is to give spinal anesthesia. Okay. And the second is to do a lumbar puncture. So can you tell me what is a lumbar puncture used for? Anyone? What is lumbar puncture used for? Meningitis. Okay. What are we collecting in lumbar puncture? We are collecting CSF in lumbar puncture. Correct. And in spinal anesthesia, what is the drug that I give into the CSF? What is the name of the drug that I give into the CSF in spinal anesthesia? Propofol. No. I give local anesthetic agent. Correct. I give my local anesthetic into the CSF. Okay. Now, one very important question to ask. What is the space that I give spinal anesthesia in, or where do I find the CSF in? Do I find it in the dural space, epidural space, subdural space, supraarachnoid space, subarachnoid space? Where do I find it? Yes. So please remember this. This has been asked recently in the NEET PG exam. So they had asked lumbar puncture is done in which space, or spinal anesthesia is given in which space. So it is given in the subarachnoid space. This is the space where you will find CSF. Okay. So another very important question that has been asked multiple times in FMGE exam. What are the layers that you pierce with this spinal needle? What are the layers that you pierce to reach the subarachnoid space? So from outside to inside, can you guys tell me the layers? What is the outermost layer? Yes, so your skin subcutaneous tissue will be the outermost layer. After that, what is the next layer? Durameter, no. Then you have your spinous processes of the vertebra. Okay, so on top of the spinous processes, you have a ligament which is called as supraspinous ligament. Supraspinous ligament. Okay. After that, in between the vertebral processes, you will find another ligament. Anyone, what is that? Interspinous ligament. In between the spinous processes. Okay, that is your interspinous ligament. What about the ligament that is present after the interspinous ligament? Very good. That is your ligamentum flavum. Okay. After ligamentum flavum, what space am I entering into? What is the space that I enter into? This is your epidural space. This is also a very important question. Why? Because many a times in the exam they will ask, to reach the epidural space, which layers do you have to traverse? So then you know it is skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, and then epidural space. Okay. Now, what is this layer? After the epidural space, what is the layer that I am traversing? If I put my needle inside, it will be a very tough layer. Yes, this is my durameter. Okay, durameter. Okay. Just on the inside of the durameter, what is this space called? So imagine this is my durameter. So just below the durameter, this is my subdural space. Do I have to give spinal anesthesia here in the subdural space or not? No, okay, not over there. I have to give spinal anesthesia beyond this. What is this layer? The black layer over here, this is my arachnoid matter. Okay, and this space over here, just beyond the arachnoid matter, this is my subarachnoid space. Subarachnoid space. So this is where I will give my spinal anesthesia. I will give my lumbar puncture, all of that. Okay, this is my spinal cord. The pyometer is attached to it closely. So this is how I will answer the question. Okay, so these are all the layers that we traverse to give spinal anesthesia. All right. Now, how do you identify this needle? It is a plain needle with a transparent hub that is present over here. The hub here is transparent so that you can see the flow of CSF in it. Okay. Now, what is this needle number 3 called as, and what is it used for? Needle number 3, and what is it used for? Yes, very good. This is my Toohey needle. This is my Toohey needle. Okay, what is my Toohey needle used for? What type of anesthesia? It is used for epidural anesthesia. Okay, how will I identify my Toohey needle? Toohey needle will have 2 wings over here. This is called as the wing or the flange. Another thing that my Toohey needle will have is this alternate light and dark markings. Can you see alternate light and dark markings? That is there on the Toohey needle. Okay. Main important thing is presence of this flange or wings that is there specifically in Toohey needle. Okay. Now here again I can see Toohey needle, but along with Toohey needle I am also seeing other things. So can you tell me what is this? What are all these other things? I can see a catheter over here. I can see a loss of resistance syringe over here. So this whole thing is my epidural set. Okay. So instead of giving just one injection, if I want to put a catheter into my epidural space, I will use this epidural set. Okay. Or what is this type of anesthesia being given over here? It's a small child, and at the edge of his buttocks, I'm putting a needle over here. What is this type of anesthesia called? It's a type of regional anesthesia only. It will basically numb everything in this area and beyond in the child. Yes, very good. This is called as caudal anesthesia. Okay. So this is my caudal anesthesia. So can you tell me caudal anesthesia is given in till how many years of age can I give this? Caudal anesthesia. It can be given up to 8 years of age. Okay. So these are my different types of instruments used for spinal anesthesia, epidural anesthesia, caudal anesthesia. All right. Okay. Now tell me, they all fall under central neuraxial blockade. Okay. So whenever we talk about regional anesthesia, can anyone tell me what is the main drug that we use in regional anesthesia? For giving regional anesthesia. What is regional anesthesia? Your patient is awake but the part of the body where the surgery is going to be carried out is numb. Okay. So regional anesthesia basically has two things. One, if you block the nerves coming out of the spinal cord. So this is called as central neuraxial blockade. In central neuraxial blockade, I have three types of anesthesia. One is spinal anesthesia, one is epidural anesthesia, and one is caudal anesthesia. Okay. Then what is the second type of blockade that we have? Second type of blockade that we have is peripheral nerve blockade. So what do I do in peripheral nerve blockade? I find individual nerves and I block them. So any idea what individual nerves am I talking about to be blocked? So yes, I can find the femoral nerve and block it. So my leg will not have any sensation. I can find my sciatic nerve and block it. Okay, I can block the bunch of nerves that is present over here. What is that? Yes, it is brachial plexus. So my brachial plexus, when it is blocked with local anesthetic, the entire hand will get anesthetized and the patient will not have any sensation. Okay, understood? So this is my central neuraxial blockade. Okay. Alright, now can you guys identify what is this type of anesthesia that you're seeing over here? This one. This has been asked previously in the FMGE exam, a NEET PG exam, INI-CT, all exams. So here you are tying a tourniquet. Okay. Once you tie a tourniquet, blood cannot go back and it cannot enter into the hand. Now, after that, you put an IV line over here. Can you see there is an IV line over here, and through that IV line I give local anesthetic agent. So this entire hand becomes anesthetized. So any kind of surgery in this part of the hand, it can be carried out in this block. Yes, this is called as Bayer's block or IV regional anesthesia. Okay, Bayer's block or IV regional anesthesia. Alright. Now, what is the main complication of Bayer's block or IV regional anesthesia? Can you tell me? Suppose this tourniquet, I deflate it and the drug enters from the local anesthetic, enters into the systemic circulation, goes to the heart, goes to the brain. What will happen in that case? What is the main complication? With Bayer's block, what is the main complication? The local anesthetic agent is entering into the systemic circulation. It can cause local anesthesia, systemic toxicity. Okay, or LAST. Anyone knows about LAST, or you guys want me to discuss about LAST? What is the treatment, everything? So I'll discuss LAST, but before that, look over here. Okay, can you see with the ultrasound, you're trying to look at the brachial plexus nerves, and then you're putting a needle there and giving local anesthesia. So this is your brachial plexus block. Okay. Alright, so let me explain LAST for you guys. So what is local anesthesia? Systemic toxicity. Okay. So first of all, you need to know what is the dose of lignocaine, maximum dose of lignocaine with adrenaline and without adrenaline. And then tell me the dose of bupivacaine, maximum dose that is allowed. Anyone? This is asked very frequently in the exam. Maximum dose of lignocaine with adrenaline and lignocaine without adrenaline. Okay, so the maximum dose of lignocaine with adrenaline is 7 mg per kg and without adrenaline is 5 mg per kg. Okay, and the maximum dose of bupivacaine is 2 mg per kg. So what happens if I give too much dose, if I exceed the dose, if I overdose the patient with local anesthetic? So the local anesthetic level in the blood will increase. So it will go to the brain, it will go to the heart. Okay. When this local anesthetic goes to the brain, it will cause initially seizures and then coma. When it goes to the heart, it causes a cardiac arrest. Okay. So what can happen to my patient? This is called as local anesthesia systemic toxicity. Local anesthesia systemic toxicity. Okay, so what is happening to my patient in this? He is going into toxicity of the local anesthetic. So as a result of this, he is going to die. So what do I do in that case? What is my drug of choice? Anyone? My drug of choice in this case is 20% intralipid. Okay. So what does my 20% intralipid do? Intralipid is basically full of fat. So when I give this 20% intralipid, all my drug that is there, suppose my drug is attached over here to the brain, to the heart. So this drug is very lipid soluble. So it leaves the brain, it leaves the heart, and it enters into this lipid. Okay. And from after it enters into this lipid, so it will leave the heart, it will leave the brain, and my heart and brain will start working normally again. Okay. So this is what happens when I give intralipid. So this is my local anesthesia, systemic toxicity. Clear? Okay. Next, the anesthesia monitor. I want you to identify each and every monitor that is present on this. Anesthesia monitor. Tell me the name of each and every monitor that is present on this. Okay, what is the first monitor that I see and what am I seeing over here? Very good, that is my ECG. What is the second monitor that I am seeing over here and the value is written over here? This 83 above is what? The 83 above is my heart rate, correct? After that, what do I have over here? Capnography or EtCO2, end-tidal carbon dioxide levels. Very good. After that, what am I having over here? The blue thing and the 97%. Yes. What is the name of this graph that comes with saturation with SpO2? Name of this graph, it is called as plethysmography. Plethysmography. Okay, and this is my saturation. This is my capnograph. And this is my EtCO2 value. This is my heart rate and this is my ECG. Okay. Alright. Now, what do you see? Forget about this. Don't worry about this monitor. It is the Bis monitor. What do I see below red one and here? 167, 69 is what? And what is the red waveform? Yes, this is my blood pressure. And this waveform is waveform of invasive blood pressure. Anyone, what is invasive blood pressure and where is it taken? It's not non-invasive blood pressure, it is invasive blood pressure. In invasive blood pressure, you will get a waveform like that. Yes, very good. So in invasive blood pressure monitoring, I will put a small catheter into my radial artery and I will get the BP of the patient with every heartbeat. Okay, so every heartbeat ka BP I will get of the patient. So this is my anesthesia monitor and you should be able to identify each and every part on it. Now, how do they ask you in the exam? So in the exam, they mark this on the anesthesia monitor and they ask what is the name of this monitor. So the name of the monitor was capnography. Now you should also know the normal values. What is the normal value of heart rate, normal value of blood pressure, normal value of saturation and normal value of end-tidal carbon dioxide? Batao. Normal value of heart rate 60 to 100 beats per minute. Normal value of blood pressure, normal blood pressure is 120 by 80. Okay, normal saturation is more than 95% at room air and normal EtCO2 is 35 to 45 mm of Hg. Okay, these are your normal values. Okay. Now, in this, can you identify this instrument for me and what is it used for? Can you see what I am doing over here? I am keeping it over here near the neck, near the brachial plexus, and then I am trying to locate the brachial plexus with it, and then I am putting a needle over there. I am not locating the jugular, I am locating the brachial plexus with this. Okay, so this is my peripheral nerve locator. This is my peripheral nerve locator. Okay, so what is the use of my peripheral nerve locator? It helps in locating nerves. So what will it do? Can you see over here, there is 15 milliampere written over here. So it will give current, it will stimulate the nerves over here. Once I find the nerve, I have located the nerve, then I will give local anesthetic and I will block that nerve. Okay, so that is my peripheral nerve locator. What is the other way of locating my peripheral nerves? I want to locate the brachial plexus, the femoral nerve, the sciatic nerve. The other way is by locating it with ultrasound. Okay, so these are my ultrasound transducers. You should know the names of these transducers. This is your linear probe. This is your curvy linear probe because it's curved and linear. And this one over here is your cardiac probe. Clear? So these are my ultrasound transducers. Okay. Now, next, before we do all this, I just want to discuss a few drugs with you because they are very, very important. Now, everyone keeps asking me, ma'am, what is the most important thing in anesthesia? If I have to revise a few days prior to the exam, ma'am, what should I revise? So, what is the most important topic in anesthesia? It is drugs in anesthesia. Okay, anesthesia pharmacology. So, they definitely ask you these drugs every single time. Now, I want you guys to tell me what are the 4 main classes of drugs in anesthesia. First one is your intravenous anesthetic agents. So can you give me examples of these? Intravenous anesthetic agents, Propofol, very good. Next is my inhaled anesthetic agents. So can you give me examples of these? There are only 4 classes of drugs that you need to know. Isoflurane, sevoflurane, desflurane, halothane, all of them. Okay. All right. Next class of drugs. What do I call my muscle paralysis agents? Muscle paralysis agents? Muscle relaxants. Okay. Muscle relaxants. They are also called as neuromuscular blocking agents. Neuromuscular blocking agents. Okay. So in my neuromuscular blocking agents, what are the drugs that I have? Yes, I have succinylcholine or scoline. I have atracurium. I have vecuronium, and I have rocuronium. All these drugs. Okay. And what is the last class of drugs that I have in anesthesia, which are very important? Local anesthetic agents. These are the ones I use in regional anesthesia. Okay. So what are the important local anesthetics? 2 main important ones. One is lignocaine, one is bupivacaine. And there is one more which has come now. It is ropivacaine. Okay. So let's see each and every drug and what they usually ask about these drugs in the exam. So can anyone tell me Propofol ke bare mein any 2-3 points? 2-3 important points asked in the exam. First of all, it is the most commonly used agent all over. Okay. Now, can you tell me Propofol contains what in it? In which kind of patients, in which allergy will I avoid Propofol? Yes, I will avoid Propofol in egg allergy. Why? Because it contains one protein of egg, which is the egg lecithin. Okay. Next, what is the color of Propofol? Very easy to identify. Sometimes they ask you to identify in the exam. It is milky white in color. It looks exactly like milk. Okay. So who died because of Propofol? Overdose. This they will not ask you in the exam, but who died of Propofol overdose? Michael Jackson. Very good. Okay. All right. Next question that they will ask you about Propofol is, now it contains egg, it contains fat, it contains all triglycerides. So you cannot keep it out in the open. Once you open it, you can't keep it with the environment. The bacteria will come and settle on it and form colonies. Okay. So can you tell me, if the bacteria can form colonies on this, for how many hours once I open the ampoule of Propofol, can I use it? Yes, not 4 hours, but it should be used in 6 hours once open. Okay. Now, if I give a continuous Propofol infusion for more than 48 hours, what is the problem that I will get? You get Propofol infusion syndrome. Okay. So what happens in Propofol infusion syndrome? Because of continuously giving high doses of Propofol, the cell metabolism goes into anaerobic metabolism. You get lactic acidosis, you get rhabdomyolysis, and green colored urine in the patient, and the patient can die because of this. This is called as Propofol infusion syndrome. Okay. In daycare surgery, what is the anesthetic agent of choice? Daycare surgery, anesthetic agent of choice is propofol. Absolutely correct. Okay. Now, next question that I want to ask you guys about propofol is, what are the good properties about propofol? It is anti-emetic in nature. Remember this. It is anti-emetic. Okay. So it avoids vomiting, and it is also anti-pruritic. What do you mean by anti-pruritic, anyone? Anti-itching. Very good. Now, next question. Ketamine. Now, can you tell me any important things about ketamine? What does ketamine cause to the intracranial pressure, and what does it do to the intraocular pressure? And what does it do to the blood pressure and the heart rate? Yes. So all your IV anesthetic agents will cause decrease in ICP, IOP, BP and heart rate. But ketamine is the only one that will increase all of this. Okay. So if ketamine increases ICP, I should avoid it in which kinds of patients? In which patients should I avoid ketamine? In patients of head injury. Okay. Because they already have a raised ICP. Then I should avoid it in patients who have high intraocular pressure. So patients of glaucoma. Okay. Alright. If it increases the blood pressure, then it is preferred in which kind of patient? Hypertension. Okay. If my patient has a lot of blood loss, so trauma patients or patients who are in shock, I will prefer to give ketamine as induction agent because it will maintain the blood pressure. Okay. Alright. Now, ketamine causes maximum bronchodilation. It dilates all the bronchi. So, in which patients will I prefer to give ketamine if it causes bronchodilation? Yes. In asthmatic patients, I will prefer to give ketamine because of its bronchodilation. Okay. Alright. Anything else about ketamine? Yes. Ketamine causes hallucinations. Remember that? It causes something called as emergence delirium. Anyone, what is emergence delirium? Okay, when the patient wakes up after receiving ketamine anesthesia, he will start singing songs, he will start saying rubbish. Okay, so that is because the patient becomes delirious. This patient also has some hallucinations. Alright, and one more thing you get with ketamine, that is out of body experience. What is that called as? Dissociative anesthesia. Okay, they ask this many times in the exam, especially this term, dissociative anesthesia. What is dissociative anesthesia? You will have an out of body experience when you are under anesthesia with ketamine. So you will feel that you are standing at the end of the room, corner of the room, and you're looking at yourself. Okay, your soul is different, your body is different, and you're looking at yourself. So that is dissociative anesthesia seen with ketamine. Alright. Yes, in babies we prefer to give ketamine because it maintains the respiratory rate, so babies don't go into apnea. Alright. Now, next agent we have is Eatometer. So can you tell me, there are only two questions asked about Eatometer. One is Eatometer is preferred in which patients, and second one is Eatometer causes what complication? Yes, very good. Eatometer is a cardio-stable agent. It will maintain heart rate, blood pressure, everything very well. So it is preferred in cardiac patients. Okay. And what is the complication with Eatometer? Anyone? Very good, Sushma. So you will get adrenal gland suppression with Eatometer. So what happens if you have adrenal gland suppression? So what if I have adrenal gland suppression? What is the problem? I will have low cortisol production, low steroid production. Okay, and steroids are responsible for maintaining your blood pressure, for maintaining your sugar levels, everything. Okay, all right. Now, next agent that we have over here is thiopentone. So, first of all, what class of drugs does thiopentone belong to? It is a barbiturate. Okay, where do I prefer thiopentone? Where do I avoid thiopentone? Anyone? ECT, no. For ECT, for electroconvulsive therapy, we have another IV agent called methotrexatal, which is used. Very good, Amodini. You will avoid it in asthma as it can cause bronchospasm. Okay, we prefer it in neurosurgery. Okay, neurosurgery. Why? Because it reduces the intracranial pressure very well. Second place that we prefer it is in hyperthyroidism. Hyperthyroidism. Okay, why? Because it prevents the peripheral conversion of T4 to T3. So you will prefer it. Asthma may you will avoid it, and porphyrias may you will avoid it. Okay, this is all about thiopentol. Next, identify these vaporizers and what are the agents in them. So this purple colored vaporizer is, I just did all the vaporizers and the colors in the last class. Okay, so it is isoflurane. Isoflurane is preferred in 3 types of surgeries. One is liver surgery. Okay, anything else other than liver surgery? Cardiac surgery, very good, and neurosurgery. Okay, so many a times they ask you what is the inhaled anesthetic agent of choice in cardiac surgery? What is the inhaled anesthetic agent of choice in neurosurgery? So you will answer all of them as isoflurane. What is the MAC of isoflurane? I have already discussed with you guys. MAC is 1.4. Okay. Next we have sevoflurane over here. So sevoflurane is the most commonly asked question in the exam. And what is the question? Where is it preferred? Okay. So where do we prefer it? We prefer it in children. Why? For inhalational induction. Anyone, what is inhalational induction of anesthesia? So in children, they won't allow you to put an IV line. They will start crying, zor ka they will cry. Okay. So instead of putting an IV line and giving propofol or thiopentol through the IV line, you just hold the mask on their face and ask them to inhale sevoflurane. Now your sevoflurane is very, very sweet smelling. So the child will not get irritated and he will inhale it. The minute he inhales it and it goes into his lungs, and then from the lungs it goes into his brain, he will become unconscious. Once he becomes unconscious, then you put the IV line and you carry out the anesthesia of the patient. Okay, clear? That is inhalational induction. So this is a very common question asked in the exam. Sevoflurane is preferred in children because it helps in inhalational induction of anesthesia. Okay. Alright. What is the third agent that you guys can see over here? Third agent seen is desflurane. Correct? The blue one is desflurane. Okay. Before that, what is the MAC of sevoflurane? We forgot to discuss that. MAC of sevoflurane is 2. MAC of desflurane is 6. Okay. Now desflurane is preferred in which patients and it is avoided in which patients? Desflurane is mainly preferred for short surgeries. Okay. So it is the inhalational agent of choice for daycare anesthesia, where you have all short surgeries. Why? Desflurane will go quickly into the body and it will come out also quickly out of the body. So that's why we prefer desflurane in daycare anesthesia. Okay. We avoid desflurane in which condition? We avoid it in children and in asthma. Why? Why do we avoid it in these cases? Because it's very pungent smelling. Okay. Very dirty, pungent smell. So children don't like it and asthmatic patients get bronchospasm with it. Okay, so it irritates the airways. Alright. Now, what is this last agent, red colored agent that you can see over here? Yes, this is halothane. Okay. Now, halothane is, what is the MAC? MAC is 0.75. So halothane is preferred in which patients? Halothane is preferred in asthma. Very good. Why? Because it causes bronchodilation. Okay. It was also preferred in any kind of uterine internal or external version. Okay. So if you want to move the child, move the baby and the position of the baby, you can use this. On the other hand, you will avoid halothane in which condition? In postpartum hemorrhage, because it dilates the uterus, relaxes the uterus and does not cause stoppage or bleeding of the uterus. Okay. Now, very important thing about halothane that they ask in the exam is halothane hepatitis. Anyone heard about this halothane hepatitis? Not hepatitis E. No, no. It is an autoimmune type of hepatitis. Okay. So what happens in halothane hepatitis? If you repeatedly give the patient halothane, for he comes to keeps coming to you for surgeries, and every time you give him halothane, he will start developing some antibodies against the liver. These antibodies will go and they will attack the liver and they will kill the liver. Okay. So that is called as halothane hepatitis. Clear? Okay, so we finish all our IV agents and all our inhalation agents. Next, what are these drugs? You can see succinylcholine, vecuronium, rocuronium. What are all these drugs? Yes, these are all my neuromuscular blocking agents or my muscle relaxants. Handwriting is coming very bad now. This writing pad के साथ my handwriting is very bad, but when I write on the iPad, it comes very well for YouTube classes. Okay, so how do I divide my neuromuscular blocking agents into? What two groups are they divided into? What are the two groups they are divided into? Yes, you have the depolarizing and the non-depolarizing one. So in the depolarizing, what is the only agent that we study about for the exam? In the depolarizing agents, we have only one agent that you need to know, and that is succinylcholine. Okay, succinylcholine. Alright. Now, can you guys tell me something about succinylcholine? So, succinylcholine is avoided in patients with which electrolyte abnormality? With which electrolyte abnormality will you avoid succinylcholine or scoline? It is also called as scoline. Yes. So avoid it in patients of hyperkalemia. Why? Because succinylcholine can increase the serum potassium levels. So if already serum potassium levels are high because of hyperkalemia, you will avoid it. Avoid succinylcholine. Okay. Second, succinylcholine can cause what in the heart? It will act on the heart and cause what? Arrhythmia. What arrhythmia? Which arrhythmia? I want to know that. This is like me asking you, dinner में तुम क्या खाने वाले हो, and you say खाना. Okay? Arrhythmia मतलब खाना. क्या खाना खाने वाले हो? डोसा खाने वाले हो, इडली खाने वाले हो, पराठा खाने वाले हो, क्या? No, it causes bradycardia. Okay? It causes bradycardia. Okay. Once I give succinylcholine to my patient, what is the first thing that happens in him? Does he immediately get paralyzed or you see something else in him? Immediate paralysis or you see something else? Yes. So first I will see fasciculations and then I will see paralysis. Okay. Now, do I require reversal agent when I give succinylcholine or not? Is reversal agent required or not? It is not required. Okay. Drug of choice for rapid sequence induction. So whenever I want to rapidly intubate the patient, it's an emergency. Suppose he was walking on the road, hotel say he was going home, khana khake, full stomach, walking on the road, got hit by a motorcycle. Now this patient has come for emergency surgery. He is full stomach. You give Selix maneuver. You give drugs which act very quickly, anesthetize him and put the tube in. Okay. So drugs which act very rapidly. First one that we will use is Propofol or Ketamine depending on the blood pressure of the patient. Second, to give muscle relaxation, we will use succinylcholine. Why? Because it is rapidly acting. Okay. Alright. Next class of drugs, we have the non-depolarizing agents. So in the non-depolarizing agents, we have vecuronium, rocuronium, atracurium, all of them. So I'll ask you one-liner questions about all of these that are asked in the exam. So most cardiostable muscle relaxant. What is the most cardiostable muscle relaxant out of all these non-depolarizing agents? What is the most rapidly acting non-depolarizing agent? What is the shortest acting non-depolarizing agent? Okay. So the most cardiostable one is vecuronium. What is the most rapidly acting? No, it is rocuronium. What is the shortest acting one? Shortest acting non-depolarizing agent? Mevacurium. Okay. And can you tell me any specific thing about atracurium? Atracurium is your favorite non-depolarizing agent past. Yes. So atracurium requires no reversal. It undergoes something called as Hoffman's elimination. Okay. So what is Hoffman's elimination? In the plasma, the atracurium will get metabolized on its own. It does not require dependency on kidney, on liver, on any organ. Directly it will go into the plasma and it will get metabolized and its action will get over. Okay. So Hoffman's elimination, because of Hoffman's elimination, if there is kidney or liver failure, in that case, you will prefer to give atracurium as the muscle relaxant of choice. Okay. Second important thing about atracurium is it releases histamine. So because it releases histamine, it can cause fall in blood pressure, it can cause allergic reaction. Okay. So it can cause all those things. Alright. So these are all our muscle relaxants. Now the last class of drugs that we have is our, what is this? Lignocaine, bupivacaine, intralipid. Yes. So these are my local anesthetic agents. So what do I use my local anesthetic agents for? What is local anesthetic used for? Regional anesthesia. Very good. Now, the favorite question that they like to ask is the dose of lignocaine and bupivacaine with and without adrenaline. So lignocaine without adrenaline is 5 mg per kg. Lignocaine plus adrenaline is 7 mg per kg. Dose of bupivacaine is 2 mg per kg. Now, can you tell me what is the problem with bupivacaine? It can affect which organ the maximum? Yes, it can affect the heart the most. Okay. So they will ask which of these is the most cardiotoxic local anesthetic. So most cardiotoxic local anesthetic is bupivacaine. Clear? Okay. And this drug 20% intralipid. In which condition do I give this 20% intralipid? Yes, I will give this as an antidote in local anesthesia systemic toxicity. Okay, in last or local anesthesia systemic toxicity, I will give this drug. Clear? Okay. All right. Now, identify this. First of all, first a little bit monitors. Over here, we missed out. Okay, these are two special monitors. Only if you see it, it's okay. You can remember it. The one that is attached here near the brain in the frontal and the temporal lobes, this is called as the Bis monitor. Full form of Bis is bispectral index. It is a depth of anesthesia monitor. It will measure whether you are giving overdosage of anesthesia or underdosage of anesthesia. Okay, and this monitor that you can see you see it is going into the radial artery, and here you can see the blood pressure on the monitor. What is this called as? Yes, this is called as the invasive blood pressure monitoring. Okay, and this invasive blood pressure monitoring you put mainly in the radial artery. Clear? Okay. Now, next, okay, identify this condition. This is the EtCO2 of the patient. This is the temperature of the patient. The patient is also getting here muscle rigidity. Muscles have become all rigid, and this has all happened after you gave some inhalational agents to the patient. So what condition are we talking about, and what is the treatment of this condition? Yes, absolutely correct. Malignant hypothermia is the condition. What is the treatment? So what are you getting over here? You are getting continuous increase in EtCO2. This is called a step ladder pattern of EtCO2. Okay, so you are getting continuous hypercarbia. Temperature mein what are you getting? You are getting hyperthermia, muscle rigidity, and all this is happening after you have given some gases to the patient. Okay, so what are the precipitating features of malignant hypothermia? Malignant hypothermia is caused by what drugs? Treatment is dantrolene sodium. Many of you have written. Absolutely correct. IV dantrolene. What is the cause? One cause is succinylcholine. And what is the main cause other than succinylcholine? Your inhaled anesthetic agents. Okay, all your inhaled anesthetic agents. So all your SIBO, halothane, desflurane, all of them can cause this. Okay, so they will give you a case scenario in which they'll say that patient has been giving general anesthesia. Suddenly his EtCO2 levels go up, his body becomes extremely warm, and all the muscles become rigid. Mouth opening is reduced. There is trismus. So what is happening? You are getting malignant hypothermia. What is the drug of choice for induction of anesthesia then? Drug of choice for anesthesia. If I know that my patient has malignant hyperthermia, how will I give him anesthesia then? Yes, I will give him propofol for induction, that is for the beginning of anesthesia, and I will maintain the entire anesthesia also with propofol. Okay? Alright. Now, identify this condition. So, I gave this drug to the patient. After that, he is having seizures. After seizures, he is going into coma. And initially, he had bradycardia. Then he had arrhythmias. And now he has gone into cardiac arrest. All of this happened after I gave this one drug to the patient. So what is this condition? Yes, Devesh. So what is that condition? If I give my local anesthetic, I am giving lignocaine, correct? If I give my local anesthetic intravenously, instead of giving it around the nerves, I give it intravenously, or I overdose on the local anesthetic. So what happens? It goes to the brain, causes seizures and causes coma. It goes to the heart, causes bradycardia, arrhythmias and cardiac arrest. So what is this condition? I just discussed it with you guys over here. And I gave you the treatment also of it. Very good, Dinesh. So this is local anesthesia, systemic toxicity. Okay. So either I overdose the patient with the drug, or instead of giving the drug around the nerves, I give it directly into the blood vessels. So it will go directly into the systemic circulation and go to the heart, brain, everywhere. Okay. What is the treatment for local anesthesia systemic toxicity? 20% intraliquid. Very good. Okay. All right. Now, different types of anesthesia cylinders. Identify the gases kept in them. So, French blue color cylinder has which gas? Stores which gas? Nitrous oxide. Very good. Black cylinder with white shoulder. Looks like the Unacademy t-shirt. Black body, white shoulder. Yes, this is my oxygen cylinder. Remember, Unacademy is the oxygen to your success in the exams. Okay, so that's how you can remember the oxygen cylinder color. Okay, all right. Gray color cylinder, carbon dioxide. Very good. And this one, alternate light and dark markings, alternate white and black markings. This is air. Okay. Pipeline है क्या इसमें? नहीं, pipeline नहीं है. Okay. Now pipelines also you should know the color. Blue color pipeline will carry. Blue color pipeline will carry nitrous oxide. Okay. White color pipeline will carry. बताओ सब सो गए या खाना खाने चले गए? White color pipeline will carry oxygen. Yellow color pipeline will be vacuum or suction. Okay. All right. Now, little bit about the pre-anesthesia orders regarding medication. So, on the day of surgery, should the patient take his antihypertensive medication or omit his antihypertensive medication? If patient comes to you with high blood pressure, on the day of surgery, continue or stop antihypertensives? Continue or omit? Just tell me continue or omit. You will continue the antihypertensives except two antihypertensives, ACE inhibitors and angiotensin receptor blockers. These are the ones that you will omit. Okay. Anti-diabetic agents, continue or omit on the day of surgery? Omit. Very good. So your OHAs and insulin, oral hypoglycemic agents and insulin both have to be omitted. Why? What will happen if I give my patient anti-diabetic agents on the day of surgery? It can cause hypoglycemia. Already my patient is fasting. On top of that, if I give my patient more anti-diabetic agent, he will become hypoglycemic. Okay. My thyroid medications. If my patient is hyperthyroid or hypothyroid, what should I do with my thyroid medications? Thyroxine, L-troxine and hypothyroidism, or anti-thyroid drugs like carbimazole, methimazole, propylthiouracil. What to do? Yes, any kind of thyroid medications, continue on day of surgery. Okay. Psychiatric medications, continue or stop? Antipsychotic medications? No, you will continue. You don't want the patient to have an episode of depression or psychosis perioperatively. Okay, so continue all medications except one medicine, that is lithium. Okay, lithium needs to be stopped 48 hours prior to surgery. Okay, what about my anticoagulants? I'll ask you about some specific anticoagulants. Aspirin, continue or stop on day of surgery? Aspirin is continue. Okay, clopidogrel, continue or stop? If stop, then when? Yes, stop 7 days prior to surgery. Okay, warfarin, continue or stop? And how many days prior to surgery? Yes, warfarin stop 5 days prior to surgery. Okay. Then low molecular weight heparin, last dose to be given when? And unfractionated heparin, last dose to be given when? Low molecular weight heparin, last dose 12 hours prior to surgery. Unfractionated heparin, last dose 4 hours prior to surgery. Okay, so this is about all the medications that they ask in the exam. Last one is the fasting guidelines. So, in the fasting guidelines, tell me if my patient has had water or black coffee or black tea, some clear liquids. So, after how many hours can I take him for surgery? If he's had just black tea or black coffee or water, after how many hours of clear liquid can I take him? 2 hours. Very good. If it is a child and he has breastfed, so after how many hours of breastfeeding can I take the child for surgery? 4 hours. Very good. If the patient has had full fatty meal, vada pav, pav bhaji, paratha roti, chapati, dal, after how many hours? 6 hours. Are you guys sure? 6 or 8? Yes, it is 8 hours. Okay. And if he's had a light meal, suppose he's had chai and biscuit, or if he's had a pulpy juice, mosambi juice, orange juice, pulp with the pulp, okay, then 6 hours. This is your fasting guidelines. This is asked multiple times in the exam, so you should definitely know the fasting guidelines. Okay, so that's it. What all have we discussed in part 2? The fasting guidelines, pre-anesthesia orders regarding medications, cylinders, pipelines, malignant hypothermia, local anesthesia, systemic toxicity, all the drugs and their important questions that are asked. All the, oh, we missed out this monitor. Quickly batao these 3 monitors, what are they? ये वाला monitor, can anyone identify for me? Number 1, you must have seen this. It's inserted here in the IJV. What is this monitor? This is my central line. Okay, central line, or it is also called as CVP monitoring, central venous pressure monitoring, mostly put in the internal jugular vein. Okay, what is this second monitor that I'm seeing over here? Any idea what is the second monitor that I'm seeing over here? This is my capnograph. Okay, it is used for measuring my EtCO2. So from here, it will measure the EtCO2 from this end. Okay, and what is this monitor that I'm attaching to the thumb and checking? I will stimulate the ulnar nerve over here and I'll see the movement of the thumb. Saturation, no. See over here, I'm connecting electrodes to the ulnar nerve. I'm stimulating the ulnar nerve and seeing the movement of the thumb. And by giving this current. What is this monitor called? Yes, very good, cheese. So this is your peripheral nerve stimulator. It is used to check whether the action of the muscle relaxant is over or no. Peripheral nerve stimulator. Okay. To check if the patient is unparalyzed or not. And the question that they ask in this is, what is the nerve that is stimulated in this? Okay. So that is your ulnar nerve that is stimulated in this. In peripheral nerve stimulator. Okay. Alright. Ashutosh, rebreathing का CO2 कैसे होता है? CO2 ग्राफ. Yes. Normally, your EtCO2 will touch the baseline because it is 0. Okay, this is 0 EtCO2, the baseline. In rebreathing, the EtCO2 will not touch the baseline because you are breathing some amount of carbon dioxide even during inhalation. So that will be a very low amount of carbon dioxide, maybe 5 mm of Hg, but you are rebreathing it. Okay, so rebreathing ka graph will not touch the baseline. Okay, all right. ठीक है, तो समझ में आ गया अभी सब कुछ. So we'll pack it up for today's class. Thank you so much for joining me today, guys. Tomorrow I will keep class for orthopedics. I will give all the information about it on Telegram, so you guys can use the link of Telegram. We'll be doing a quick revision of ortho, and I hope to see you guys tomorrow for the class. Okay. All right. Good night, everyone. Bye bye. Don't forget to download this PPT and use it for your PDF revision. Okay.